Finerenone for diabetic cardiorenal protection in type 2 diabetes. Diabetic kidney disease, DKD, affects approximately 40% of the 537 million adults with type 2 diabetes, T2D, globally, representing a leading cause of end-stage kidney disease, ESKD, and cardiovascular, CV, mortality. Finerenone, a non-steroidal, selective mineralocorticoid receptor antagonist, MRA, attenuates inflammation and fibrosis in cardiorenal tissues by blocking aldosterone-mediated signaling in podocytes, mesangial cells, and cardiomyocytes. Diagnosis of DKD requires persistent albuminuria greater than or equal to 30 mg per g creatinine on 2 of 3 urine samples within 3 to 6 months and/or estimated glomerular filtration rate, eGFR, less than 60 ml/min/1.73 m superscript 2 for greater than or equal to 90 days in a patient with T2D. First-line management includes SGLT2 inhibitors and RAAS blockade. Finerenone is indicated as add-on therapy in patients with T2D, eGFR greater than or equal to 25 ml/min/1.73 m superscript 2, and urinary albumin-to-creatinine ratio, UACR, greater than or equal to 30 mg per g to reduce the risk of sustained eGFR decline, ESKD, CV death, non-fatal myocardial infarction, and hospitalization for heart failure. Key points. Note: Finerenone is initiated at 10 mg orally once daily in patients with eGFR greater than or equal to 60 ml/min/1.73 m superscript 2 and titrated to 20 mg once daily after 4 weeks if potassium less than or equal to 5.0 milliequivalent/L and eGFR remains greater than or equal to 60 ml/min/1.73 m superscript 2. In patients with eGFR 25-60 ml/min/1.73 m superscript 2, the starting dose is 10 mg orally once daily. No further titration is recommended. The Fidelio DKD trial demonstrated a 18% relative risk reduction, RRR, in the composite renal outcome, HR 0.82, 95% CI 0.73 to 0.93, P equals 0.001. with Finerenone versus placebo over median 2.6 years. The Figaro DKD trial showed a 13% RRR in the composite CV outcome, HR 0.87, 95% CI 0.76 to 0.98, P equals 0.026, over median 3.4 years. Serum potassium must be monitored within 1 month of initiation, after each dose increase, and every 3 to 6 months thereafter. Finerenone is contraindicated if baseline potassium greater than 5.0 milliequivalent/L. UACR reduction with Finerenone averages 31% from baseline by 4 months, independent of blood pressure changes. The AHA/ACC/HFSA 2022 Heart Failure Guideline recommends Finerenone, Class IIA, level of evidence, A, in patients with T2D, CKD, and prior CV events or high CV risk. The ESC 2023 Diabetes, Prediabetes, and Cardiovascular Diseases Guideline includes Finerenone as a recommended add-on therapy, Class 1, Level B, in T2D with albuminuric CKD. Finerenone reduces the risk of first hospitalization for heart failure by 23%, HR 0.77, 95% CI 0.60 to 0.98, in Figaro DKD. The number needed to treat, NNT, to prevent one major renal or CV event over 3 years is 25, 95% CI 16 to 59. Hyperkalemia occurs in 18.8% of patients on Finerenone versus 9% on placebo in Fidelio DKD, with absolute risk increase of 9.8%. Discontinuation due to hyperkalemia occurs in 2.3%. Finerenone is not recommended in patients with eGFR less than 25 ml/min/1.73 m superscript 2 or those on dialysis. Overview and epidemiology. Diabetic kidney disease, DKD, defined as chronic kidney disease, CKD, attributed to diabetes mellitus, is coded under ICD-10 as E11.22, type 2 diabetes mellitus with diabetic nephropathy. It affects approximately 212 million individuals worldwide, representing 39.5% of the estimated 537 million adults with type 2 diabetes, T2D, as of 2021, IDF Atlas, 10th edition. The global prevalence of DKD varies by region. It is highest in low and middle-income countries, LMICs, where it accounts for up to 50% of incident ESKD cases, compared to 30 to 40% in high-income countries, HICs. In the United States, the National Health and Nutrition Examination Survey, NANS, 2017 to 2020 data indicate that 37.8% of adults with T2D have albuminuria, UACR greater than or equal to 30 mg per g, and 18.6% have eGFR less than 60 ml/min/1.73 m superscript 2. The incidence of DKD is rising at 3.2% per year globally, driven by increasing T2D prevalence, aging populations, and obesity. DKD disproportionately affects certain demographic groups. Men are 1.4 times more likely than women to develop DKD, RR 1.4, 95% CI 1.3 to 1.5. Racial disparities are pronounced. Non-Hispanic Black individuals have a 2.1-fold higher risk, RR 2.1, 95% CI 1.8 to 2.5, and Hispanic individuals a 1.6-fold higher risk, RR 1.6, 95% CI 1.4 to 1.9, compared to non-Hispanic white individuals, independent of access to care and comorbidities. Age is a strong determinant. The prevalence of DKD increases from 12% in adults aged 20 to 39 years to 48% in those aged 60 to 79 years with T2D. Pathophysiology. The pathophysiology of diabetic cardiorenal injury involves chronic hyperglycemia-induced oxidative stress, inflammation, and fibrosis mediated through multiple interconnected pathways. Persistent hyperglycemia activates protein kinase C, PKC, increases advanced glycation end products, AGEs, and promotes hexosamine and polyol pathway flux, all of which contribute to endothelial dysfunction and glomerular hyperfiltration. These processes initiate podocyte injury, mesangial expansion, and tubulointerstitial fibrosis in the kidney, and myocardial stiffness, microvascular dysfunction, and left ventricular hypertrophy in the heart. A key mediator in this process is aldosterone, which binds to mineralocorticoid receptors, MR, in non-epithelial tissues including podocytes, mesangial cells, vascular smooth muscle cells, and cardiomyocytes. In diabetic states, MR activation occurs independently of angiotensin II and is amplified by local tissue aldosterone production. MR overactivation leads to NADPH oxidase-driven reactive oxygen species, ROS, generation, upregulation of pro-inflammatory cytokines, e.g., TNF-alpha, IL-6, MCP-1, and activation of transforming growth factor beta, TGF-beta, promoting extracellular matrix deposition and fibrosis. In the kidney, this results in albuminuria, glomerulosclerosis, and progressive eGFR decline. In the heart, MR activation contributes to myocardial fibrosis, diastolic dysfunction, and arrhythmogenesis. Clinical presentation. The classic clinical presentation of diabetic kidney disease with cardiorenal involvement includes progressive albuminuria, declining eGFR, hypertension, and signs of volume overload. Microalbuminuria is present in 28% of patients with T2D at diagnosis and increases to 40% after 10 years of disease duration. Macroalbuminuria develops in 15 to 20% of patients over 10 years. Hypertension is present in 75% of patients with DKD, with mean office blood pressure of 146/84 mmHg at the time of albuminuria detection. Symptoms are often absent in early stages. When present, fatigue occurs in 62% of patients with eGFR less than 60 ml/min/1.73 m superscript 2, peripheral edema in 48%, nocturia in 41%, and dyspnea on exertion in 37%. Pruritus is reported in 29% of patients with advanced CKD. In the context of concomitant heart failure, orthopnea occurs in 31%, paroxysmal nocturnal dyspnea in 22%, and reduced exercise tolerance, NYHA class 2 to 3, in 54%. Diagnosis. The diagnosis of diabetic kidney disease with indication for Finerenone therapy follows a stepwise algorithm endorsed by KDIGO 2024 and ADA 2024. Step 1. Confirm type 2 diabetes using one of the following: HbA1c greater than or equal to 6.5%, 48 mol/mol, fasting plasma glucose greater than or equal to 126 mg per deciliter, 2-hour plasma glucose greater than or equal to 200 mg per deciliter during OGTT, or random glucose greater than or equal to 200 mg per deciliter with symptoms. Step 2. Assess kidney function with serum creatinine to calculate eGFR using the 2021 CKD-EPI creatinine equation. Repeat measurement within 90 days to confirm persistence. Step 3. Measure urinary albumin-to-creatinine ratio, UACR, on a first morning void or random spot urine sample. Repeat twice within 3 to 6 months. Diagnosis requires 2 of 3 values greater than or equal to 30 mg per g with greater than or equal to 90 days apart. Laboratory reference ranges. Key points: eGFR, normal greater than or equal to 90 ml/min/1.73 m superscript 2, CKD stage 3A, 45 to 59, 3B, 30 to 44, 4, 15 to 29, 5, less than 15. UACR, normal less than 30 mg per g, microalbuminuria 30 to 299 mg/g, macroalbuminuria greater than or equal to 300 mg per g, serum potassium, normal 3.5 to 5.0 milliequivalent/L, serum sodium, 135 to 145 milliequivalent/L. Management and treatment. No acute management is required for initiation of Finerenone in stable outpatients. However, patients presenting with acute kidney injury, AKI, or hyperkalemia, K plus greater than 5.5 milliequivalent/L, should not start Finerenone until stabilized. Monitoring includes continuous ECG if potassium greater than 5.5 milliequivalent/L, intravenous calcium gluconate 1g over 2 to 5 minutes, insulin 10 units with 25 g dextrose, and sodium polystyrene sulfonate if needed. Volume status should be assessed clinically and with BNP if heart failure is suspected. Finerenone initiation is delayed until potassium is less than or equal to 5.0 milliequivalent/L and eGFR has stabilized. Finerenone, generic, is marketed as Kerendia brand. The recommended dosing is. References. 1. Heinegar et al. The Pharmacokinetics of the Non-Steroidal Mineralocorticoid Receptor Antagonist Finerenone. Clinical Pharmacokinetics. 2023, 62, 12-1673-1693. PMID, 378756671. https://pubmed.ncbi.nlm.nih.gov/378756671. DOI 10.170/S40262-023-01312-9. 2. LVR et al. Cardiovascular renal protective effect and molecular mechanism of Finerenone in type 2 diabetic mellitus. Frontiers in Endocrinology. 2023, 14:1125693. PMID 3686034. https://pubmed.ncbi.nlm.nih.gov/3686034. DOI 10.3389/Fendo.2023.11256993. 3. Zhang H. et al. Diabetic kidney disease, From Pathogenesis to Multimodal Therapy, Current Evidence and Future Directions. Frontiers in Medicine. 2025, 12:16311053. PMID 408612114. https://pubmed.ncbi.nlm.nih.gov/408612114. DOI 10.3389/med.2025.16311053. 4. Georgianos P.I. et al. Albuminuria and cardiorenal risk. Current opinion in cardiology. 2023, 38, 4331-336. PMID 370169948. https://pubmed.ncbi.nlm.nih.gov/370169948. DOI 10.1097/HCO.0000000000000001055. 5. Shokravi A. et al. Cardiovascular and renal outcomes of dual combination therapies with glucagon-like peptide-1 receptor agonists and sodium glucose transport protein 2 inhibitors, a systematic review and meta-analysis. Cardiovascular diabetology. 2025, 24, 1370. PMID 410298853. https://pubmed.ncbi.nlm.nih.gov/410298853. DOI 10.1186/S12933-025-02900-8. 6. Hobbs FDR et al. Low-dose spironolactone and cardiovascular outcomes in moderate-stage chronic kidney disease, a randomized controlled trial. Nature Medicine. 2024, 30, 123634-3645. PMID 393499629. https://pubmed.ncbi.nlm.nih.gov/393499629. DOI 10.1038/S41591-024-03263-5. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.